Hello, Professor Drake. Thank you for being here in this interview. I speak on behalf of the SMU. We're very keen having you here, sharing your knowledge. With being said, I would like to ask you a few questions regarding the most common or most important urology trials for functional urology. For instance, I would like, if you have something to comment about the upstream trial. Do we have any more evidence? Are we waiting for more data, more trials? What can you say about that?
Well, first of all, to say thank you to the SMU. The EAU is very happy to have a partnership and a friendship, and it's been a fantastic meeting to attend. The upstream trial, this was for urodynamics for prostate surgery trial, the randomized evaluation of assessment methods. We've done a lot of interpretations. I think we did 14 papers out of it, and we've covered every aspect that really is crucial. In other words, we've managed to come up with predictive factors that tell us which people will do badly if they have surgery and which ones will do well to guide us in what we recommend to patients. Now, what was frustrating is we still can't give anybody any information about post-void residual as a decision-making factor. I would love to have a proper evaluation of post-void residual, but actually it turns out to be a very complex parameter indeed. And sadly, I don't think that we'll be able to get that from the upstream study. This needs to be another carefully designed study, though getting funding for such a study will be quite difficult. The main thing to be aware of is that it is selective to exclude neurological disease. The upstream study, it was an exclusion criterion if there was a neurological disease present. And this is perhaps the big missing feature of our field, is that there hasn't been a study to do urodynamics in neurological disease. Whether or not before surgery, it's all been a descriptive cohorts, case series type of scientific evidence that we're working with, which is a frustration.
I see.
So that's lacking from upstream, and I would love our community to come together and design a good neurological urodynamics study.
And in the meantime, can we rely on the information that we got from the trial to the clinical practice, in which we have high risk factors and low risk factors for men with different type of symptoms, and whether or not going to a prostate surgery, if they will have a good outcome or not? Can we rely on that?
We could certainly rely on that information for the person without neurological disease.
Okay.
It's very solid information indeed. And it's also very logical information, because it focuses on that you would really expect voiding symptoms to be the thing to improve after relief of outlet obstruction. So if a man has got bad voiding symptoms and they're what is bothering him, then he's got a good prospect of improving, provided he's not got too many comorbidities. Exactly. If it's storage symptoms, you should be so careful. Even if voiding symptoms are present, the storage symptoms could get worse, and that's where we need to be careful. When I say worse, it can be very bad. So if a man is not bothered by voiding symptoms, is bothered by storage symptoms, you improve the voiding, but the storage symptoms get worse, that will be an unhappy patient.
Exactly. And speaking about storage symptoms and moving from upstream to another trial, for instance, overactive bladders in young women or women without any comorbidities, any comments on the future trial, something that we should know about it?
Yes, so that's just come out in The Lancet. The first author is Mohammed Abdel Fattah, and it was a very large study, more than 1,000 women with severe overactive bladder, considering sacral nerve stimulation or botulinum injections. Urodynamics was done before the interventions, and it looked to see whether there was a advantage, superior outcome from surgical treatment if urodynamics was included in the assessment. It turned out to show no significant difference, no significant advantage, and so again, it's going to be a selective use of urodynamics. And I think both studies, upstream in particular, but also future, please bear in mind the message is not urodynamics is useless. It's urodynamics should be considered as part of the armamentarium for understanding better what's wrong with the patient. And if you use it in that way, it's an incredibly valuable tool.
And with that being said, would you recommend any other diagnostic route in those patients with overactive bladders? But if they go to further lines of treatment, such as toxin botulinum or sacral nerve modulation, I know it's a very uncommon diagnosis, bladder outlet obstruction in women. Should we assess that before sending patients with overactive bladders to rule out obstruction? What would you recommend on that?
I wouldn't really support routinely excluding outlet obstruction in women. That seems non-logical.
Okay.
Well, it's very rare. You must do I think it's really focus on the basic evaluation. So the chance of obstruction is very small, but if there is a pelvic organ prolapse present, that can cause obstruction. But then the pelvic organ prolapse needs treating. So it's a case of do the basics well. And please do a bladder diary. The bladder diary is gold dust information. You look at the bladder diary and you see exactly what's going on. If the patient hasn't filled it in, you explain to the patient that it's gold dust information, please do it correctly, and then look at it. Because that's the way you'll see, are they truly going with a substantial enhancement in frequency? And certainly how often they are going to the toilet and how often they're having incontinence are real drivers behind the problem. And I think if you don't see the bladder diary, there's a high risk of being misled by how the patient describes it. They tend to describe the very worst experience that they're getting. The time they had incontinence in a public setting, but most of the time they're okay. You have a real risk of over-treating if you don't do the bladder diary. And I think our colleagues are a little prone to over-treating. It's quite easy to offer a treatment. Oh, well, if the patient said they've got urgency, that's almost considered enough to make the diagnosis. Exactly. My view is that's foolish. Yes, what they say of the urgency is the starting point of the assessment. You then want to corroborate it with the symptom score and the bladder diary and physical examination and really see how they get on with medications. See if there is a chink of improvement. May not be enough, but if there is some improvement with medication, then you know that you are dealing truly with overactive bladder syndrome. If there's no improvement, question the diagnosis. Don't just escalate to the more interventional treatments.
And possibly that's why we need to tailor treatments or tailor diagnostic routes so that we can offer a proper treatment. Many thanks, Professor Drake, for your time. Once again, we're very keen to having you here in this conference. Thank you very much.
Thank you for having me.